Well, greetings and welcome to the Science of Childhood Cancer lecture series hosted by the St. Jude Comprehensive Cancer Center. My name is Greg Armstrong, and it is my great pleasure today to welcome our speaker, Melissa Hudson, who I know very well as one of my close colleagues. Together, we are co-leaders of the Cancer Control and Survivorship Program at the Comprehensive Cancer Center here at St. Jude. And now I'm delighted to introduce Dr. Hudson. Melissa is a full member of the Department of Oncology and the director of the Division of Cancer Survivorship and the Charles E. Williams Endowed Chair in Cancer Survivorship here at St. Jude. In 1993, Melissa initiated the After Completion of Therapy program, the ACT program, our long-term follow-up program for survivors of childhood cancer. Since that time, hundreds of individuals from across the globe have visited the campus to view the clinic and model it in other places. Now, Melissa's won numerous awards, including most recently the American Society of Pediatric Hematology Oncology and Northwestern Mutual Award for Excellence in Childhood Cancer Survivorship. But there are two key things I want you to know about Melissa. First, over 20 years ago, and with a handful of others, she initiated version 1 of COG's long-term follow-up guidelines for survivors of childhood, adolescent, and young adult cancers. Now in version 5, this provides risk-based, survivor-focused care for children all around the world. And in 2008, along with Les Robison, Melissa initiated the St. Jude Lifetime Cohort, an incredible platform for understanding the long-term outcomes of our survivors and a platform for intervention. So with all that, Melissa, it's a privilege to have you here.
Thank you for that kind introduction, Greg. And I will go ahead and jump in and share my slides. I'd like to thank the series organizers also for allowing us to have this lecture focused on survivorship research. It's really exciting topic to present to you. So my learning objectives are listed on this slide. Appreciate the spectrum of long-term and late effects developing after childhood cancer, to recognize the impact of late effects on duration and quality of survival, and to understand how survivorship research has advanced childhood cancer care and outcomes. So survival rates for childhood cancer continue to rise, such that in the United States, more than 80% of children diagnosed with cancer will achieve 5-year survival. And survival estimates are comparable globally across other high-income countries. Contributors to this progress include participation in collaborative clinical trials, elucidation of cancer pathobiology that has been translated into novel therapeutics, advances in diagnostic imaging, radiation technology, and supportive care, and recognition of late effects. Childhood cancer survivors are at increased risk for a spectrum of physical and psychosocial morbidities that, depending on specific agents and modalities, may affect growth and development, organ function, prospects for future fertility and reproduction, risk for subsequent carcinogenesis, and many aspects of psychosocial functioning. Health concerns are typically related to the specific cancer or treatment modality, but may be related to childhood cancer experience and its subsequent impact on the survivor and the family. Importantly, health concerns are reported by virtually all long-term survivors. Smita Bhatia and Les Robison articulated a timeless model for pediatric cancer survivorship research that I will use as a framework for my discussion this afternoon. Appropriately, survivorship research starts by characterizing health-related and quality of life outcomes in cancer survivors. And these efforts have aimed to describe adverse outcomes in a systematic fashion across the age spectrum, to determine the magnitude of risk associated with cancer and its treatment, and to define the impact of cancer experience on quality of life and survival. The organization of pediatric cancer cohorts has been essential in advancing knowledge about late effects of childhood cancer. So this slide lists numerous cohorts from North America and Europe that have contributed to this effort. I will largely feature the results of investigations from the two cohorts organized and coordinated by St. Jude investigators, the Childhood Cancer Survivor Study and the St. Jude Lifetime Cohort Study. So a brief background about the methods of both of these studies. First, the Childhood Cancer Survivor Study, or CCSS, is a multi-institutional retrospective cohort study funded in 1994. The cohort is comprised of over 25,000 5-year survivors from 31 institutions in North America, diagnosed with common pediatric cancers before age 21 and between the years of 1970 and 1999. The CCSS was the first large cohort study to collect detailed treatment information on participants for correlational studies of self-reported outcomes. This cohort includes a sibling comparison group and a biorepository. The St. Jude Lifetime Cohort Study was established in 2007. Eligibility criteria for participation include diagnosis of a cancer between 1962 and 2012, treatment at St. Jude Children's Research Hospital, and survival of at least 5 years from diagnosis. Participation in St. Jude Life involves comprehensive clinical assessment, typically accounting for 3 to 4 days on campus, during which the survivor provides a self-report of behavioral, medical, and psychosocial outcomes. The survivor undergoes laboratory and diagnostic testing of organ function and standardized neurocognitive and performance testing, as well as biospecimen collection. Now, first, I'll start with the CCSS. CCSS investigators led by Dr. Kevin Effinger were the first to quantify the burden of cancer-related morbidity in a large cohort of long-term survivors followed for a median of 17 years from diagnosis. The cumulative incidence of participants experiencing at least one self-reported health condition 30 years after diagnosis was estimated at 73%, and 42% for a severe, disabling, or life-threatening condition or a condition that caused their death. A follow-up study led by Dr. Greg Armstrong evaluating CCSS participants aging into their 4th and 5th decades observed the marked excess in morbidity experienced by aging survivors noted by the maroon curve compared to that of the sibling group noted by the yellow curve. Clinical assessments of participants in the St. Jude Lifetime Cohort Study disclosed previously undiagnosed health conditions in a substantial proportion that increased in prevalence with advancing age and longer elapsed time from diagnosis. And in this cohort, the estimated cumulative prevalence of any chronic health condition was almost 96% by age 45 years and 81% for a serious, disabling, or life-threatening condition. Now, leveraging data from the St. Jude Lifetime Cohort Study, Dr. Nikhil Baka developed a novel method of disease burden measurement, the cumulative burden, which incorporates multiple health conditions and recurrent events into a single metric that considers competing risks. So this figure shows the commonly used cumulative incidence metric that reflects the onset of cardiac events in a study of Hodgkin lymphoma survivors in St. Jude Life. By age 50, the proportion of controls and survivors with a grade 1 through 5 chronic cardiac condition appear to be similar. However, by evaluating the total number of both chronic and recurrent conditions per individual with a cumulative burden, or here depicted per 100 individuals, you can see that at no point do controls reach the burden of conditions experienced by survivors. The cumulative burden also provides a method that highlights multimorbidity across organ systems. So this figure illustrates the proportion of organ-specific conditions noted by various colors in various diagnostic groups of survivors at 30, 40, and 50 years of age. The cumulative burden of community controls across age groups is noted on the far left with the red bar. One can see that the burden of some conditions increase over time, as in the case with cardiac disease and Hodgkin lymphoma survivors, while other conditions remain relatively static in the case of neurologic toxicity and central nervous system tumor survivors. These patterns provide insight about conditions to prioritize in long-term follow-up of specific survivor groups and the latency to their appearance. Now, despite the survival gains achieved in childhood cancer, treatment-related multimorbidity contributes to a disparity in survival with increasing time from diagnosis compared to individuals without cancer, as noted in this CCSS analysis led by Dr. Stephanie Dixon and recently presented at ASCO. Health-related mortality, represented in the red line, is a major contributor to increasing all-cause mortality, noted in the black line, with increasing time from cancer diagnosis. This excess mortality, late mortality specifically, has prompted reconsideration of the metrics of success in pediatric oncology. So a St. Jude investigation led by Dr. Annalyn Williams and Yutaka Yasui performed an analysis using SEER data to illustrate excess mortality trends in individuals under 20 years of age diagnosed with cancer. Historically, 5-year survival has been the benchmark of success, as the majority of deaths within this time are related to progressive disease or acute toxicities of therapy. And you see a steady decline in these deaths from 1985 to 2015, largely resulting from advancements in pediatric cancer treatments. Between 5 and 10 years, excess mortality reflects a mixture of cancer-related deaths from recurrent refractory disease, as well as emerging deaths associated with treatment-related toxicities. And consistent with data reported by the CCSS, excess deaths 10 or more years from diagnosis is most likely related to health-related complications rather than cancer recurrence or progression. So overall, despite the steady decline in excess deaths between 1985 and 2016 in this cohort, the total annual number of excess deaths declined only modestly when excess deaths between 5 and 10 years and beyond 10 years are considered. And what's remarkable is looking at these figures, which highlights differences in patterns of annual excess deaths across pediatric cancer diagnostic groups, providing evidence of decreasing excess deaths achieved with modification of treatment for the childhood ALL survivors on the left, and in contrast, increasing excess late deaths in individuals treated for Hodgkin lymphoma despite implementation of risk and response-based treatment strategies. So collectively, these data provide strong support for redefining success with a measure that considers risk of death beyond 5 years. In addition to concerns about excess mortality, it's important to appreciate the quality of survival and health experienced by children and adolescents treated for cancer and how this changes with aging. So a CCSS investigation demonstrated a high prevalence of poor health status among survivors compared to siblings that increases rapidly with age and is related to an increasing burden of chronic health conditions. And so this is represented with survivor impairment and health noted in the blue line compared to their SIBs in the yellow line. 2- to 4-fold excess prevalence was observed in the specific measures of health domains studied, and this investigation also was able to identify risk factors for impaired general health, mental health, and overall performance function that would help target vulnerable sociodemographic, treatment, and behavioral risk groups. In addition to health challenges, survivors experience financial distress perceived to be due to cancer diagnosis or treatment. So in this St. Jude Life study, Dr. Ai-Chan Wang led a team that evaluated financial hardship in participants who were age 32 at evaluation and 24 years from diagnosis. And this study measured material, coping, behavioral, and psychological domains that contributed to hardship by the survivor's self-report. One can see that the prevalence of individual components of financial toxicity ranged from 22% for material hardship to 51% for psychological hardship, with approximately 1/3 of survivors reporting impact in one domain and 2/3 in 2 or more domains. And then evidence for material hardship was among survivors was supported by 22% endorsing the impact of cancer on their financial situation, 52% expressing concerns about ability to pay for health care or medications, and 33% relating inability to see a doctor or go to the hospital because of finances. So importantly, as noted in this figure, all components of hardship, whether material, psychological, or behavioral, were significantly associated with excess risk of somatization, anxiety, depression, and suicidal ideation. So these data underscore the importance of assessing financial hardship in survivors reporting emotional distress, as well as assessing emotional distress in survivors reporting financial hardship, and of course, facilitating referrals for psychosocial services and interventions to address these issues. So to anticipate, remediate, and prevent cancer treatment-related morbidity, survivorship research aims to characterize groups at high risk and mechanisms of treatment-related outcomes. And so these efforts have focused on identifying patient factors that increase the risk of adverse outcomes, determining vulnerabilities associated with specific cancer diagnosis, and defining relationships between treatment and adverse events. And so there are many examples of research investigations that have advanced understanding of these factors underpinning pediatric cancer treatment toxicity. I will highlight a few in the next series of slides. The first is a systematic and serial assessment of cognition, endocrine function, and hearing among children with low-grade glioma that was spearheaded by Dr. Tom Merchant and his colleagues. And this was a very innovative study that systematically looked pre-diagnosis and followed these patients to look at the effects of the cancer and its treatment on cognitive decline over time. In fact, in looking at this study, one could see that survivors who were younger at diagnosis, that was more impactful than even the radiation dose, as seen in this figure, which modeled IQ scores in relation to time since diagnosis. One could see that patients younger than 5 years of age experienced the greatest decline in cognition, providing strong support for delaying radiation and efforts to reduce exposure to normal brain tissue. Neurocognitive function in childhood cancer survivors is frequently and more immediately associated with central nervous system tumors and central nervous system directed therapy, such as cranial radiation, neurosurgery, and intrathecal chemotherapy. But as previously presented, survivors experience a high burden of chronic health conditions in adulthood that also may increase the risk of cognitive impairment. So a St. Jude Life study characterized this risk of neurocognitive impairment associated with chronic health conditions in adult survivors who did and did not receive CNS-directed therapy. And so one can see in both CNS-treated and non-CNS-treated survivors a high or very high severity burden score, okay, and this is noted by high as blue box and very high as red triangle. They were associated with an increase of global neurocognitive impairment compared to those who did not have conditions or had a low burden score. A dose-response relationship was seen between the burden score and the risk of global neurocognitive delay in impairment, in CNS-treated survivors. And then when specific CNS exposures were examined, survivors who received more than 30 gray of cranial radiation were at highest risk for global impairment associated with the high severity burden score. And the odds ratio there was almost 13-fold. Cardiovascular and pulmonary conditions were associated with specific cognitive deficits in CNS-treated survivors noted in the top panel on the right, but not in non-CNS-treated survivors. And so these data suggest that reduced cognitive brain reserve associated with CNS-directed therapy may make survivors more vulnerable to adverse cognitive effects of cardiopulmonary conditions as they age. Now, cardiac outcomes have been the focus of many late health outcomes investigations, appropriately because they are the primary medical cause for morbidity and mortality that is non-cancer related in our long-term cohorts. The comprehensive treatment data and longitudinal follow-up of CCSS participants facilitated an investigation led by Dr. Dan Mulrooney that was among the first to establish pediatric-specific dose thresholds for anthracycline and heart failure, identifying a more than 5-fold excess risk for heart failure among survivors who received 250 milligrams per meter squared or higher of an anthracycline. A follow-up study by Dr. Armstrong and colleagues observed that the risk of heart failure and other major cardiac events was associated with exposure to anthracycline chemotherapy and chest-directed radiation therapy in a dose-dependent manner, and the impact of combined modality therapy that had cardiotoxic potential. The impact of cancer treatments on reproductive outcomes have increased in priority over time with improvement in long-term survival. So Dr. Sklar and Dr. Dan Green have led seminal investigations in the childhood cancer survivor study that have advanced understanding about the magnitude of risk and patient and treatment factors contributing to this risk. Now, the cumulative incidence of premature non-surgical menopause This is noted here by not menopausal, the proportion not menopausal by age at last menstrual period was 8% in female participants compared to 0.8% in siblings, representing a 13.2-fold excess risk. And this study identified risk factors for premature menopause, such as older age, increasing ovarian radiation dose, increasing alkylating agent score, and a diagnosis of Hodgkin lymphoma. This slide illustrates the impact of gonadotoxic treatment exposures on the proportions of survivors not menopausal by age at last menstrual period. And so panel A shows the impact of alkylating agent chemotherapy alone, panel B, abdominal pelvic radiation therapy alone, and then panel C showing a more precipitous decline in the proportion not menopausal by age at last menstrual period, by age and years rather, following treatment with both alkylating agents and abdominal pelvic radiation. In the clinically assessed St. Jude Life cohort, Dr. Wasim Schmeideli led a team that evaluated premature ovarian insufficiency, which they defined as persistent amenorrhea combined with biomarker FSH of more than 30 before age 40. And so among females in the St. Jude Lifetime cohort, 10%, almost 11% experienced POI. And this study permitted designation of independent risk factors that included ovarian dose, radiation at any dose, and the cyclophosphamide equivalent dose of 8,000 milligrams per meter squared or greater. Now, while many investigations of gonadal and reproductive function in boys and men treated for childhood cancer survivors have utilized biomarkers like FSH and inhibin B, the availability of semen analysis in over 200 male participants in St. Jude Life permitted important correlative studies evaluating cyclophosphamide equivalent dose and the prevalence of impaired spermatogenesis. So as illustrated in this figure, the cyclophosphamide equivalent dose negatively correlated with sperm concentration. Impaired spermatogenesis was less likely if the dose was lower than 4 grams per meter squared. However, the finding of normospermia at high cyclophosphamide equivalent doses noted in green by the green bar, and azoospermia at low exposures suggests the impact of genetic variation on this risk. Revisiting our pediatric cancer survivorship model to identify high-risk groups and the mechanisms of treatment-related outcomes, we also need to consider other factors, and these include comorbid health conditions, health behaviors, and familial and genetic factors. So there's excellent studies that illustrate these concepts, which are particularly pertinent to survivor counseling and health management, and so I'll highlight a few of those in the subsequent slides. Considering the burden of chronic disease experienced by our survivors, attention to established risk factors for cardiac disease is essential. So Dr. Greg Armstrong undertook an important investigation evaluating the relative contribution of modifiable risk factors on the development of major cardiac events in aging adults in the CCSS. And this effort leveraged data from longitudinal evaluation of more than 10,000 five-year survivors who were a median of almost 34 years of age. One analysis studied the relative contribution of hypertension and cardiac toxic treatment modalities to the development of heart failure and observed a rate ratio of 34 among survivors with hypertension and no anthracycline exposure, 8 for hypertension with anthracycline exposure, and almost 90 for hypertension plus anthracycline exposure. This represented an almost 45 relative excess risk due to the interaction. So these data indicate that hypertension potentiates anthracycline-associated risk for heart failure, and similar outcomes were seen for multiple traditional CV risk factors, increasing the risk of cardiac events, highlighting the importance of prevention measures in our cohorts as we are following them long term. Another CCSS study led by Dr. Sabine Miller investigated the risk of stroke in adults treated with cranial radiation during childhood and the contribution of atherosclerotic risk factors to late occurring stroke. So in this study, over 14,000 survivors and 4,000 siblings contributed data to the analysis. At a mean follow-up of 23 years from diagnosis, there were almost 300 late occurring strokes, and you can see that it's marked in excess in survivors compared to siblings, and the cumulative incidence increased from about 1 at 10 years to 12 by 30 years. They noted a dose relationship with radiation exposure with a hazard ratio up to 11 when doses exceeded 50 gray or greater. And in a multivariable analysis that was limited to CNS tumor survivors, risk factors that were independently predictive for stroke included 50 gray or greater cranial radiation, any alkylating agent versus none. And again, here we go, those atherosclerotic risk factors that can be modified and controlled, diabetes and hypertension or hypertension alone. So health behaviors are also important to consider for their potential to exacerbate or reduce the risk of late effects. And so in this regard, we have a growing body of evidence for mitigation of late effects with physical activity. And in one of the first studies, Dr. Lee Jones led an investigation that looked at exercise and risk of cardiovascular events in Hodgkin lymphoma survivors. The results of this study demonstrated that meeting recommendations for guidelines for vigorous exercise as defined by 9 or greater MET hours per week actually was associated with a dose-dependent lower risk of a cardiovascular event that was independent of the cardiovascular risk profile. And so the survivors who had this benefit are those represented in the yellow curve. Another CCSS study led by Dr. Emily Tonarezos demonstrated the impact of exercise on psychological burden of over 6,000 participants who were followed for a median of almost 8 years. And so this table summarizes the prevalence ratios for specific outcomes by levels of vigorous exercise. Positive associations were seen for the level of exercise and psychological outcomes such as depression and somatization, cognitive domains, and cancer pain at the highest level of vigorous exercise. Lastly, if I haven't convinced you to get on that bike or treadmill, the outcomes of this CCSS study investigating associations of exercise and mortality led by Dr. Jessica Scott provided evidence again of a benefit of vigorous exercise. And specifically, this study demonstrated a significant inverse association across quartiles of exercise and all-cause mortality after adjusting for chronic health conditions and treatment exposures. Now, switching gears to genetic factors, there's actually burgeoning evidence about the contribution of genetic factors to both the development of childhood cancer and risks for acute and late health outcomes. As previous speakers in the series have featured elegant work on cancer predisposing germline mutations and pharmacogenomics, I will briefly highlight some emerging data that hold promise for guiding and refining precision survivorship care. And in the first study, Dr. Yadav Sapkota led a St. Jude Life and CCSS collaboration that evaluated the contribution of a polygenic risk score and its interplay with cancer therapies to hypertension. So the polygenic risk score was calculated using established blood pressure loci from the general population. And you see the figure illustrates the ratio of the observed number of hypertensive survivors to that expected by polygenic risk score decile on the x-axis. So among survivors with a PRS in the top decile, the prevalence of hypertension was greater than expected in all cohorts. And so the cohorts here are the CCSS expansion and original cohort, which are self-reported hypertension, and St. Jude Lifetime cohort, which is clinically assessed. These investigators also looked at the adjusted attributable fraction for hypertension by specific cancer therapies considered as risk factor and the polygenic risk score. And so this figure shows that survivors who, among all survivors, the polygenic risk score contributes 21% to the polygenic risk score, 15.7% attributable to cancer therapies, and the remaining is a combination of both. And so together, it appears that the polygenic risk score is actually more influential than the cancer therapies. And you can see that this stays relatively consistent across subgroups based on body mass, age, and exposure to hypothalamic pituitary axis radiation. And in fact, survivors with a polygenic risk score in the top decile had an odds ratio that was almost threefold risk for hypertension prevalence. And this risk was exacerbated by being overweight or obese, and also among those who were exposed to hypothalamic pituitary radiation. And another emerging data related to genetic risk profiles, Dr. Xiaoming Wang leveraged whole genome sequencing data among St. Jude Live participants and evaluated the role of pathogenic and likely pathogenic mutations in DNA repair processes in the development of subsequent neoplasms. And this was based under the hypothesis that the 6 major DNA repair pathways actually may be exacerbated by treatment exposures and lead to oncogenic instability and an increased subsequent neoplasm risk. And so these are the categories of DNA pathway mutations that were evaluated. And the figure indicates the number of survivors with pathogenic and likely pathogenic variants color-coded by the pediatric cancer subtype, and the variants, those that had pathogenic, likely pathogenic variants in 98 genes. 3 groups with elevated risk were identified, and these included female survivors who had mutations in homologous recombination genes and received high doses of chest radiation or anthracyclines. They had a 4-fold increased risk of subsequent breast cancer. Survivors who had mutations in homologous recombination genes and received high doses of alkylating agents had a 15-fold increased risk of subsequent sarcoma. And survivors who had mutations in nucleotide excision repair genes and received high doses of NEC radiation had a 13-fold increased risk of subsequent thyroid cancer. So these data provide insights into the mechanisms of treatment-related carcinogenesis that can inform precision survivorship care. The ultimate goal of survivorship research is to translate observational research into evidence-based clinical care guidelines and validated individual risk prediction models to help guide our survivorship care. So there have been national and global efforts and long-standing collaborations that have aimed to standardize follow-up throughout the lifespan, specifically to promote healthy lifestyle, to provide ongoing monitoring of health status of our survivors, to facilitate early identification of late effects, and to provide timely interventions for late effects. The development of surveillance recommendations for subsequent breast cancer in female survivors of childhood cancer serves as an exemplar of collaborative work in the clinical translation of observational research. So I'd like to highlight this now. Long-term follow-up established that female survivors of childhood cancer experience elevated rates of breast cancer with a cumulative incidence of 13 to 20% by age 40 to 45 years, and as high as 35% by age 50 in survivors of Hodgkin lymphoma treated with chest radiation, which represents a risk comparable to that of BRCA mutation carriers. Breast cancer risk exhibits a linear dose relationship with chest radiation dose. However, lower dose exposure, lower than 20 gray, to larger volumes of breast tissue, as illustrated in this figure, is also associated with a substantially increased risk. Treatment with the radiation field that exposes the ovaries decreases the risk of breast cancer, with decrease remaining statistically significant after adjusting for the dose of chest radiation. And this is, again, a CCSS study by Dr. Kaya Moskowitz. And in contrast, treatment with alkylating agent chemotherapy did not modify breast cancer risk, as noted in this figure. Now, a St. Jude Live investigation led by Dr. Matt Earhart was able to uniquely characterize both treatment and genetic risks for breast cancer. Breast cancer risk in the St. Jude Live cohort of female participants exposed to chest radiation after and other chemotherapeutic agents after a high dose anthracycline here is noted to be as comparable to the risk after chest radiation and a risk associated with a BRCA mutation. And specifically, anthracyclines 250 milligrams per meter squared or greater remain significantly associated with a risk of breast cancer in models that excluded survivors who had cancer predisposing gene mutations. And this also excluded those who had, they excluded the women who had predisposing mutations, chest radiation, or both, with a chest radiation dose of 10 gray or greater. Soberingly, subsequent risk of death as a result of any cause was higher among childhood cancer survivors than SEER controls in a recently completed study, again by Dr. Kyle Moskowitz, and remained elevated even after adjusting for breast cancer treatment. And this study was determined to be caused by 5 times greater mortality related to health-related causes, including other subsequent malignant neoplasms and cardiovascular or pulmonary disease. However, encouragingly, survival by detection method, as reported in the Earhart study, indicates that smaller breast lesions were identified by surveillance, and this may ultimately translate into better survival in our cohorts as we have increasing numbers to follow and follow these trends. These data have been translated into clinical practice guidelines based on the observation that the median time to diagnosis of breast cancer from radiation exposure is 15 to 20 years, with cases being diagnosed as early as 8 years from exposure. So breast cancer surveillance is currently recommended for all women treated with chest radiation, yearly beginning 8 years after radiation or at age 25, whichever occurs last. Dual imaging is recommended, as is typical for women at high risk for a breast cancer predisposing genetic mutation. And presently, shared decision-making about the need for breast cancer surveillance among women treated with anthracycline chemotherapy is recommended, although there is an ongoing pooled analysis that is evaluating chemotherapy-associated risk factors for breast cancer, and the results of this analysis may prompt refinement of this recommendation. These data have also been translated into a risk prediction model that was recently published again by Dr. Kaya Moskowitz, and they used data from breast cancer cases and female survivors in the CCSS and validated this in an independent cohort of female survivors in the Dutch late effects and later cohorts. The data included in the model are listed: age, chest radiation dose, chest radiation within 1 year of menarche, anthracycline exposure, age at menopause, and first degree relative with breast cancer. And you see here the 10-year breast cancer estimates at 30 years of age and 40 years of age with the area under the curve calculations. The highest breast cancer risk was noted in women who are premenopausal, older than 40 years of age, who received mantle within 1 year of menarche, who had a first degree relative with breast cancer. And the model showed really good calibration with the expected to observe ratio of the number of breast cancer cases of 0.92. And so this is the preferred model when these data information is available. Again, considering our model of survivorship research, results of observational research have been translated into interventions that are focused on primary prevention and newly diagnosed children with cancer, and secondary prevention and measures among long-term survivors. So targets for long-term survivorship research have varied, and due to the limited time, I can't go into a lot of detail about these studies. I'll just tell you about the specific targets, which have focused largely on increasing survivors' knowledge about their health risks, their ability to manage chronic symptoms, motivating practice of healthy behaviors, motivating adherence to follow-up and screening, and self-management and advocacy. So these interventions have also focused on educating, activating, and supporting healthcare providers in the delivery of high-quality survivorship care. Survivorship research has clearly been instrumental in the elucidation of predictors and pathophysiology of treatment-related adverse outcomes, and have guided the development of risk stratification of primary therapy and organization of risk-based health surveillance recommendations that can facilitate early detection of late effects. Outcomes research has also identified targets for intervention to prevent and remediate cancer treatment-related morbidity, as I previously demonstrated. So again, we'll go back to what is the evidence from pediatric cancer cohorts. We definitely have seen benefits of survivorship research, and this study that leveraged data from over 35,000 participants in the childhood cancer survivor study, we find support for that risk-adapted treatment strategies, lower treatment exposures for favorable disease presentations are associated with a reduction in mortality over the 3 decades during which the participants were treated. And a similar pattern of reductions in chronic health conditions was seen over these same treatment eras within CCSS. Evaluations of patterns of morbidity over time that indicate that also that risk-adapted therapy for Hodgkin lymphoma has resulted in a significant reduction in serious long-term outcomes, is noted in this slide, which illustrates the cumulative incidence of severe to fatal chronic health conditions in almost 3,000 5-year Hodgkin lymphoma survivors. And here they're a median of almost 36 years of age, diagnosed from 1970 to 1990. And the figures illustrate cumulative incidence by age of specific types of conditions, sex, the impact of sex, and as well as the decade of treatment. And so compared to survivors treated with chest radiation therapy at doses of 35 gray or greater, in combination with anthracycline or alkylators, it would be typical for individuals in the early treatment eras for Hodgkin lymphoma therapy. Contemporary treatment regimen that for a low and intermediate risk Hodgkin lymphoma that eliminates many of these exposures was estimated to lead to a 40% reduction in the risk of a severe to fatal chronic health condition. Similarly, another CCSS study observed that survivors of ALL treated on standard and high-risk regimens in the 1990s experienced lower health-related mortality that was similar to that of the general population. However, systematic assessment of ALL survivors in the St. Jude Lifetime Cohort study indicate that the spectrum, but not the magnitude of morbidity has changed. Noting that here, survivors treated with contemporary chemotherapy alone regimens experience a comparable morbidity to that of survivors treated on earlier protocols that included cranial radiation therapy for central nervous system prophylaxis. What we see in the more contemporarily treated regimens with chemotherapy alone is a higher prevalence of musculoskeletal toxicity and endocrine toxicity related to impaired glucose metabolism and overweight and obesity. And despite these observed changes in late mortality morbidity in the CCSS, the proportion of survivors reporting adverse health status did not decrease by treatment decade. And so this study that is featured looks at survivors diagnosed again in the CCSS from 1970 to 1999 and notes that survivors diagnosed in 1990 through 99 were more likely to report having a poor health status and cancer-related anxiety compared to those diagnosed in 1970 to 1979. Temporal changes in treatment exposures were not associated with changes in the proportion of survivors reporting adverse health status. So these data collectively underscore the importance of anticipating risk associated with cancer experience that may make a survivor more vulnerable to adverse outcomes. And these include patient, provider, and healthcare system factors noted on this slide, which influence not only the risk of late effects, but also survivors' ability to access risk-based survivorship care. And perceived to be integral to the delivery of high-quality care is a survivorship care plan, which is a personalized plan that is ideally organized by the oncology team that addresses specific components of care that are listed on this slide. Also integral is evidence-based health surveillance recommendations, which have been available since 2003 and updated regularly to reflect recommendations, new data that's emerging from the survivorship literature. And so while considered to be essential to the delivery of high quality care, limited research indicates that they have not been effectively implemented, especially in community settings where the vast majority of our long-term survivors receive their care. So providing evidence for this deficit is a recent CCSS investigation that assessed self-reported adherence to COG guideline surveillance recommendations for breast cancer, colorectal cancer, skin cancer, and cardiomyopathy. And so you can see that adherence rates across the board are suboptimal. However, positive associations were noted with adherence in the possession of a survivorship care plan, either by the survivors or providers. So there may be some hope that our care plans are beginning to be better appreciated within the community, at least from some limited evidence from this study. The contribution, as I previously said, of financial barriers to survivorship care should also be considering and understanding factors that are influencing adherence to recommended health surveillance. So this CCSS investigation noted substantial financial hardship among cohort members, especially those who had high out-of-pocket expenses, which is defined as exceeding 10% of their household income. And so this is represented by the yellow bars, and you see the specific areas of financial hardship that were assessed. Another CCSS study actually evaluated other challenges related to health insurance access and restrictions that can potentially affect survivors' access to high-quality survivorship care. Thus, a priority for future research in survivorship is to advance understanding about the perspective and barriers to survivorship care experienced at the patient, caregiver, and local environment level. And this is a figure that is drawn from the Agency for Health Care Research and Quality, AHRQ, technical brief on disparities and barriers to pediatric cancer survivorship care that was recently released. This technical brief also highlighted the need to understand barriers at the level of provider, healthcare system, and payers to survivorship care. And so the brief provides an excellent overview of existing evidence and framework for research targets and outcomes to address disparities in access to survivorship care. So considering these challenges that I've just reviewed, future priorities for survivorship care and research will require expanding our collaborations with health services and implementation sciences research to better understand stakeholder perspectives and the context of barriers to care, to help us design studies with meaningful metrics for survivorship care, to develop interventions to support access to high-quality survivorship care, and to effectively disseminate and implement these findings into real-world community settings. It's also important for us to continue our ongoing investigations, evaluating multifactorial mechanisms underpinning cancer treatment-related toxicity that will help us guide precision survivorship care, and to extend these investigations to evaluate long-term and late effects of contemporary treatment strategies. So I will end there with acknowledging our funding sources, our institutional support from ALSAC, and thanks to our survivors and families from whom we learn on a daily basis and who have been our longstanding partners and collaborations, and many collaborators nationally and globally who have contributed to these efforts. Thank you for your attention.
Well, thank you, Melissa, for a fantastic lecture. We have 10 minutes or so. Let's dive into some questions. Now, you mentioned you didn't have time to talk about interventions, but now that we have some time, there are a number of interventions ongoing now in the St. Jude Lifetime cohort. I wonder if you would mind highlighting a few of those, just to give us a sense of what are investigators focusing on and what do we think are really modifiable and changeable?
Well, currently within St. Jude Life, we have remote interventions that are focused on promoting physical activity, improving physical function, cognitive rehabilitation, looking at targets of healthy brain aging, which Dr. Kroll presented in a previous series, Science of Childhood Cancer series. So a lot of our efforts are looking long-term and aging survivors, but we also have emerging studies that are beginning to target survivors as they are on therapy. We're beginning to integrate these types of objectives within the frontline trials. And I think one of the most exciting things that we'll see if we get beyond this COVID pandemic era is studies that are actually using pharmacologic interventions that are addressing aging and survivors and the role of senolytics that you will be leading. We also have studies that are winding down that have looked at other pharmacologic interventions for improving cardiac function in our survivors who've been exposed to anthracycline chemotherapy.
Great. Number of questions here in the chat box, so thank you all for submitting. Again, please submit to all panelists. First question, Melissa, is from Anna Meadows. Anna, great to have you here. She says, very nice, Melissa, thank you for the presentation. Can you clarify what is meant by genetic risk factors impacting infertility in males after cyclophosphamide?
I think that's an emerging area of research, and there are studies really more at the level of genome-wide association studies that are exploring this. Since that data is emerging and that's not my specific area of expertise, I can't tell you the specific findings, but other than with the pattern that we've seen with the variation in exposure, we feel like there most definitely is something that is likely impacting either repair, if it's a radiation effect, or or metabolism of like alkylating agent chemotherapy that may be contributing to the differences that we're seeing in people who have exposures that one would have otherwise expected them to be infertile or to not be infertile.
Great. Here's a question from Thrisha Suresh, and she asks, what are the precautions that should be taken to prevent breast cancer after chest radiation?
First of all, try to avoid radiation. If you need radiation, have our excellent radiation colleagues, oncology colleagues, work with us in trying to limit exposure to healthy breast tissue. But precautions that should be taken, I think, are the precautions that we would otherwise recommend in the general population, and that's maintaining a healthy body weight, restricting alcohol use if you decide to drink at all. We know that those are two important behavioral factors that will translate into our survivor population, because we know that they are more vulnerable in that regard.
Excellent. And so, Melissa, here's a few questions on the mortality study from Anna Lynn Williams that you reported on. Do you think the significantly raised late excess mortality, particularly in the Hodgkin's lymphoma population, is peaking now due to the historical radiotherapy delivery use and the lag and the induction period?
No, that's really, I think, a fair assessment. And, with our late effects research, we are always, we're 10, 15, 20 years beyond the change in therapy, and so we truly anticipate with the modifications in therapy that we will see a decline. But at this point, the data is reflecting. Remember, that was survivors up to 2016, 17, and our hope is that we will see a decline in those excess mortality with our regimens that continue to refine radiation exposure, limit exposure, and integrate new agents.
Well, you answered the next question, which is, do you think this will change with the de-escalation of radiation intensity? So thank you, Melissa. So a question about precision survivorship. You noted numerous studies looking at genetic predisposition for late outcomes. And for the clinicians in the audience, I'm sure they're saying, well, when are we going to realize this in the clinic? When will this be clinically actionable? I'd love to hear your insights on that.
Yeah, presently, the strongest clinically actionable are those that are established cancer predisposing mutations that have been previously published. The thing that's exciting is all this data that's letting us know about single nucleotide polymorphisms or likely pathogenic variants that had not been previously associated with childhood cancer to identify new groups. That's not, or the polygenic risk score, looking at loci within the general population that relate to specific outcomes that are particularly prevalent in our population, like hypertension. That type of data, it's not ready for clinical real time. Our hope is it may not be in my time practicing medicine, but I think that we will get there with the creativity and innovation of our ongoing investigations that are beginning to unravel the components of genetics that are contributing to these long-term outcomes. So not now, but hopefully in the future, it will help us guide potentially even frontline treatment decision making, but potentially, our survivorship care that will help us really refine how we're targeting at-risk groups.
So here's a couple of questions from the clinical domain. In terms of interventions to improve survivorship, in particular, increased knowledge of late effects for survivors, what are your thoughts on the optimal timing of introduction of this information on late risk?
Well, I actually, when I had an active practice in lymphoma, I introduced the concept of late effects and the monitoring that would require as I was consenting patients and reviewing risks as an understanding of we are making modifications of therapy, but it's very important for us to continue to monitor. And this is our anticipated signals for late effects the magnitude of risk hopefully will be much lower based on the changes that we made. So I would recommend introducing and normalizing this as part of your ongoing care, but certainly that may not be heard at a time where you're under a lot of high anxiety with a new cancer diagnosis. I revisit, after therapy is stopped periodically to remind survivors, and it's particularly important in our population where a lot of them are children, and they may not be aware, or the discussions were primarily with their parents, and they have to own that knowledge now and understand their particular health risks so they can make informed decisions about their health behaviors and their lifestyle, et cetera.
And then here's a follow-up question to that idea. Have you found that with pediatric patients and their parents, information on late effects adds to the burden of patients already dealing with a new diagnosis? So how do you balance that burden of that delivery of information?
I think it can. I think back in the day, it was worse than it is now. Because we used to have patients that would come to after completion of therapy, and the parent was waving hands saying, "Don't talk about any of this." But I think as we have come to understand that this is an important part of informing health decisions and prioritizing, your lifestyle, et cetera, and your medical follow-up and maintaining insurance, that having the survivor understand that and understand their health risks is important. So I would say now it's not very common, although, we still have an occasional family or two that seems very distraught by hearing the information. I think when we understand how actions that can be taken, how we are going to work with them to facilitate early time diagnosis and remediation and resources, I think that can be reassuring. We always, pivot back to, this is your role. These are the health behaviors that you can do. This is what you can do. So it's not, overwhelming. We turn that anxiety around to something that is going to be beneficial to the family.
And then one last question that follows on that. Do oncologists satisfactorily address these issues at the point of care and the point of consent and diagnosis, or do you think they're even sufficiently aware of the risks?
I think they're definitely addressing it. Our families are providing consent, and so we can see that information is reviewed. I think it's probably impossible to hear all of that and really take that in when you're considering your child has a cancer and what might, the repercussions of that cancer, particularly in a very high risk cancer. So I think that's why the discussions need to be repeated and continued over time so the families can understand those risks and not to burden them again, but just to be sure that the actions they're taking on behalf of their health are appropriate, that will help them keep them engaged in care and keep them up to date about research that can help keep them healthy.
Great. Well, thank you, Melissa. It's the top of the hour, so I want to thank you for your presentation and draw an official close to the event, but I want to invite all who are interested and can stay around. We'll have an extended discussion period over the next half hour. So thank you all for coming, and please join us next week when Dr. Dan Landau of Weill Cornell Medical College will be presenting Deciphering Somatic Evolution with Single-Cell Multiomics. Also, please mark your calendar for November 4th when Dr. Kirsten Ness will present on interventions to prevent and remediate frailty in childhood cancer survivors. So thank you. Well, Melissa, thank you for staying around a little bit longer and continuing with some of the questions. I'd love to jump back to intervention for a quick second and let you tell us a little bit about one of your own intervention studies, the ECHO study, and some of the lessons learned, a highly successful study, yet at the end of that study, a real lesson learned about next steps. Love to detail that.
So I think the ECHO studies randomized survivors who were at risk for cardiomyopathy to receive advanced practice counseling with the survivorship care plan or just a survivorship care plan. So both address the risk and had recommendations that were needed for screening, for specifically echocardiography or a comparable measure of cardiac function. And so the advanced practice counseling was done over several sessions and was, highly successful and had more than a twofold increase in uptake of survivors presenting for echocardiography screening. We actually tracked that and validated it with medical records among survivors who did not have screening. We actually queried, why didn't you get it? And so that was instructive. In understanding, some of the barriers to screening. A lot of it was I didn't think it was important. I didn't have time, but some related to need for a provider understanding better what tests needed to be done and what those risks were, even though the materials provided to survivors were share this with your doctor and elaborate that information. I think the biggest issue with the echoes, even though we know that that was a good model as far as engaging and enhancing screening uptake, it wasn't a disseminable model. It could not be practically implemented because practices don't have a couple of advanced practice providers here ready to, counsel and handhold survivors, even if the sessions were brief. So currently, the ECHOES study is being transformed into a mobile health platform that will enable us to have a broader reach. And Dr. Matt Earhart is leading that initiative. And the study will also, working with implementation scientists, help us really do some homework before, in the development of this mobile application or web-based interface application that will allow us to understand better stakeholder perspectives, particularly provider perspectives. I think that's been a big problem in a lot of survivorship research, engaging community providers and understanding what their needs are. I think that hopefully working with our implementation scientist partners, we're going to be able to have a better handle on that and translating the study to something that would be more disseminable, implemented within the community setting.
Well, Melissa, that's actually a good segue into dissemination and implementation science. Would you like to enumerate some of the ongoing interactions that, you look at the model that Smita and Les put out, that circle diagram, you can't close the circle without implementing and disseminating and getting everything back to the survivor. So how are we going to do that better over the next decade?
Well, I think these partnerships with folks that are trained to do this, perhaps naively, enthusiastically, but naively back in 2003 or the years preceding the release of the Children's Oncology Group guidelines, we thought that if we built it, people would be happy to use it. And I think that over time, especially as medicine has become more complicated, we have demands on our time, we have limited time with patients. We're spending more time actually doing medical record charting and the electronic health record versus actually interacting with our patients. I think we have to learn how to meet people at point of care. And so these implementation scientists are really trained to understand those perspectives, those barriers, and those last two slides, those figures that I illustrated from the HRQ report, understanding those at every level, really getting the context of what's happening with those stakeholders is going to be critical to us. And I think that requires special training, or specific training that I didn't have. And I think that we're recognizing this science is critical to moving our interventions into the community.
Thank you, Melissa. Here's a question from Wendy Botner. Melissa, thank you for a fantastic discussion. You were discussing barriers to care. Do you have any tips on how to address barriers with insurance carriers? For example, I often encounter payers who do not want to pay for surveillance echoes during pregnancy.
The way we've encountered it, we have templated letters, and I can't say they always work. I mean, back in the day, we had very good success with providing information about women who have who've had chest radiation and they're higher risk for breast cancer. And so now we have lots of data related to that. And so we can easily get that covered by providing information that is recommended by the Children's Oncology Group. Here's some research studies that highly support this. I think the areas that we have more trouble with, and so in this specific case, echoes during pregnancy, is that's not as well studied. The cohorts are limited, but the signals for an adverse cardiac outcome is low if the patient has a pattern of normal systolic function pre-pregnancy. And so it's in those when you don't know and you need to follow, you're really having to write a letter on behalf of the patient, pulling in a lot of very personal information. So when that happens, when the data is insufficient, I try to have information about what I know about that specific patient. They may make that patient more vulnerable and pull in what I know in the literature to support it. And so it takes a personal touch with a letter with a payer. And I've been successful in some cases and not in others. It's a very difficult time for us, I think, in medicine and trying to convince some of the third-party payers who have different priorities for funding specific evaluations in our patients.
Thank you. So, Melissa, since you mentioned Senolytics, there's a question here from Ibrahim Adewald. about senolytics, and are they promising as far as a pharmacological intervention? And are you planning to test specific senolytics, or are you going to be just generally screening multiple senolytics? What's the approach?
Okay, well, I'm not going to tell them their approach. You're going to tell them because that's the study you're leading. So I'm going to turn it over to you because that's actually an innovative study that I think many people would like to hear about.
Well, we do appreciate the question. We do have a UO1 funded for a two-arm trial that will test dasatinib and quercetin against also a second agent, fisetin. These have been shown in animal models to be senolytic agents, but this will be our first in survivor study. So we'll be looking at safety and initial evidence for efficacy, and that's a trial that will start in the next few months. So good question. Melissa, let's talk about health services for a minute. You alluded to that near the end of the study, at the end of the talk, but truthfully, it's not a well-studied area. We think about what we know about survivors and their engagement with their healthcare providers, with hospital systems, payers. It seems like there's a lot of room for us to learn here. I'd love to hear your thoughts about health services and where we can go with that over the next
Well,
decade.
I think, again, just like with implementation sciences, I think we need our health services researchers to help design and give us those metrics. They have established metrics that they follow in populations, that are aging, and they use integrated healthcare system databases and Medicare and Medicaid systems to be able to track what's happening. I think the problem with pediatric survivorship care in particular is that it's a relatively smaller population. We have some segments of that population that may be in a Kaiser system or that we may be able to pull outcomes from CMS that will allow us to look at targeted outcomes, emergency room visits, or payer, or specific conditions or specific testing procedures. If they've had an echo, et cetera. But I think it's costly, and I think that we have not, especially in the United States, we don't have a system that is nationwide that allows us to do that easily. And we don't know how representative some of these other integrated systems that are used in adult populations are for our population. There have been some very creative work done at the level of kids on therapy looking at acute effects, such as admissions for neutropenic fever, et cetera. I think it becomes more challenging in long-term survivor population. That's probably where our colleagues in Europe and Scandinavia, UK, who have these health systems and public databases and registries that they can link to get more specific information about what's happening with their systems. I think in the US, we're really, really challenged with that. And we need our health services folks who are used to working in those data systems to help guide us about how we can leverage or what we can do with what the limitations that we have and what's available to us.
And Melissa, I should highlight that thanks to you and your leadership in CCSS, that will be a focus for us over the next 5 years. We'll enhance our surveys of our 25,000 participants to really understand their needs, their healthcare needs, and their gaps. And so I think that will be very informative. So we can look forward over time to see whether those health and health services related issues actually impact their long-term outcomes, which I think is still an unknown. So here's a question from Anthony Mormon. Many patients with ALL now receive very low dose chemotherapy. Is there any evidence that this has reduced morbidity, or is it too early to know?
So based on what we saw from the data I showed from St. Jude Life, those studies extended through total 15. So you're getting into contemporary therapy without chemotherapy alone. And so the data that I wanted to highlight there, or the finding, was that we still see a level of morbidity. Sometimes I think we're more concerned about some of the outcomes, like the proportion of our survivors who have abnormal body composition. We're seeing with the change from CNS-directed therapy using cranial radiation therapy to, more potent steroids, et cetera. We're seeing more musculoskeletal toxicity related to osteonecrosis. So no, we've not seen a change in the magnitude of the late effects. We just see different late effects. And so I actually took out the slide that I typically show. And so, we don't see perhaps these life-altering late effects. We're not seeing a high-grade CNS tumor after cranial radiation for central nervous system prophylaxis, for leukemia. But we are seeing a whole lot more kids, that are overweight and obese that appears to have some relationship to treatment. And we've traded toxicity. So it's more life-altering, at least in this earlier pediatric follow-up time than life-threatening. For our patients who are now having these risk-adaptive therapies, most of them are experiencing some side effects. The problem is that some of these life-altering effects really can carry on with increasing the risk for other types of chronic diseases as they age. So we want to be able to intervene and remediate those now.
So, Melissa, what are your thoughts on the role? This is from David Noyd. What are your thoughts on the role of clinical informatics to facilitate population health management of survivors at high risk for late effects?
Meaning like informatics, like electronic health record?
Yeah, I think you probably can think about that broadly. Mobile health, electronic health record, what are the opportunities there to facilitate, the health management of these survivors? I mean, considering most of them are remote, right? If there are 500,000 survivors out there, they're dispersed across the United States. That's still a difficult population to care for.
Okay, so I'll comment about electronic health systems, but I see probably they are talking more about remotely delivered interventions, et cetera. But I think there is an opportunity with with EMRs, especially if we get a very robust EMR that's really integrated within a healthcare system that many of us are using. That unfortunately, that's not really happening. Hospital systems are using variable electronic health records, and even community practices are using different ones as well. But I think that these more robust EHRs actually have opportunities for decision prompts based on exposures, to help you develop care plans. So I think a lot of the adult populations are leveraging those systems, and pediatric centers are beginning to understand the technology and the functionality of those systems. Even within it, we're looking at a change in our EMR at St. Jude, and we're trying to understand how we can utilize the functionality to help guide survivorship care. In regards to other informatics, absolutely, I think things need to move to remote platforms just to be practical, especially with the way our survivorship population is dispersed. And because a lot of the effects occur many years distant to exposures. And so, having a group like CCSS or St. Jude Life that's able to track longitudinally as people are aging is critical for us to really get a handle on what's happening with them. So we need those types of systems. I think it is the way of the future. I think one thing we learned with echoes, you design a study, and by the time you get follow-up and you publish it, technology has changed so rapidly. You're behind again. How do you do this to something that is reasonable? And I think that's what's hurting us about the COG guidelines and other guidelines is that, we're in old informatics systems, and to really get things at point of care where people can get it on their phone or, tap in some limited information and know what to do when that survivor presents to them, that's where we need to be. And I think we'll get there. I think we have a lot of creative folks that are working in this space now that will help us make that transition into something that is going to be more widely feasible and implementable in a community setting.
Well, since you're talking about guidelines, Melissa, why don't we go there for a minute? It'd be worth mentioning your efforts from the international harmonization of guidelines. That's something that has evolved over the last decade, and probably be good to highlight that.
Okay, well, I'm happy to highlight that. And I think I want to make a statement about the studies that I showed. I relied on St. Jude Life and CCSS studies because I have access to pretty slides and data from them. But international collaboration across late effects, and now with understanding and translating those observations into clinical practice guidelines, absolutely needs global collaboration. And so the effort through International Guideline Harmonization Group has been especially important because we've been able to partner and use the collective expertise for individuals who take care of children with cancer, whether they're pediatric oncologists, radiation oncologists, endocrinologists, et cetera, but also with guideline methodologists and with epidemiologists and others that are in the space of what does it do to do high quality literature review and understand the biases of that literature and how that may inform care. So I think that partnership has been critical in really improving our guidelines, and we continue to make progress. I think one of the most important things we do is we identify the deficits that are there and that need to be addressed. And so I'm really grateful for that collaboration, and I think it's one of the most important ones that we are doing within the survivorship space to advance care for our survivors.
No doubt. And then, while we're talking about guidelines, what do you think is the uptake of the guidelines? Have we measured that? Do we know the uptake at institutions or by individuals?
I don't think we have good data. I know that there's this is surveyed within the Children's Oncology group periodically, and there's a recent survey that has gone out to pediatric cancer centers that has not been published. And so I think that we try to understand who is aware, who is implementing or adhering to them. But I think the bottom line is we don't have a good understanding, because I think people understand the exposures and the potential health risks, but I think others may have specific opinions about that recommendation. I'm not going to follow that specific guideline, or that specific recommendation. So I think that there's some personal preferences in how we're doing it, which should always be a personal preference in a point of care of an individual patient. But I think that if we are talking nationally or globally, I don't think we have a good handle on how these guidelines are being used. And I think that's one thing that our health services researchers and our implementation scientists researchers can work with us to get those metrics to see what's influential and why. If they're not being used, why aren't they? What can we do to improve the consistency of care that's appropriate for that risk group?
Good. Just a couple more questions here, Melissa. I want to thank the audience for tremendous questions and for a very large number of individuals still engaging in this conversation. So here's one. In order to really fulfill or implement a late survival plan, it seems like that we need to have great collaboration between physicians, PAs, psychiatrists, psychologists, occupational therapists, nutritionists, and more. How do we do that? And how have you been successful in collaborating with the ultimate goal of getting a survivorship care plan into the hand of a survivor and having it used?
So it's not fair for me to respond to that, because I'm at St. Jude, that is well resourced, and we have all those collaborators who work with us, and we have actually a dedicated team that develops our care plans, whereas at most places it's probably a nurse, doctor, advanced practice provider who's putting the care plan together and scrambling to try to find those resources and collaborations to organize the plan of care within the institution. At St. Jude, everything is covered. Survivors in our care, we have those care needs that are met. I think the challenge for even our team at St. Jude is, as we transition for them from survivorship care to the community, how do we do that? And it's just, I don't have a magic answer to that. It's really, really challenging. And it's particularly challenging in a system, a healthcare system, and I'm saying this is the U.S. that's not valuing rehabilitation. We seemed like we're really struggling with a lot of the psychosocial issues and the that are secondary to biomedical complications. And those are particularly hard to address. So I don't have a magic issue there, other than we are very passionate about what we do. So the way we accomplish that is through a lot of phone calling and negotiating on behalf of our families. And that happens even beyond the time that they are with us as children. I would expect that almost all the late effects researchers here and clinicians are still in contact with survivors as they're aging, as they're facing health issues, and we're communicating on behalf and trying to help them. And so we do that in a perfect healthcare system. Ideally, the healthcare system would address the needs and address holistically the needs, not just a medical complication, but the rehabilitation, the psychosocial issues that are associated with the experience.
Here's a question from another angle. So, Melissa, what's being done to integrate information related to COVID into survivor databases? And what recommendations are we giving to survivors regarding COVID?
Well, there are systems. St. Jude has a data system. They're working with other global groups in collecting outcomes about COVID, the COVID experience. So it extends into long-term survivorship, but a lot of it is focused on acute care and conditions. I'm not directly involved with that. What are we saying to survivors? Get vaccinated. It's important to get vaccinated. The vaccines are safe and appear to prevent severe COVID that results in hospitalizations and deaths. So we're uniformly recommending vaccinations. A lot of our survivors that have called requesting this really have the same issues that folks who don't have cancer have, about safety and timing, et cetera, and are they more or less at risk? So we're providing the same information essentially to our survivors. It's not their survivorship experience, other than those who might still be immunodeficient. There may be different caveats about how the vaccine may work in those patients. We still want them to get vaccinated, but I think that it's more of the chronic health conditions that put them at increased risk that we're encouraging, especially in that population, to take advantage of the vaccine.
Well, Melissa, the last question is really a fitting one. It's about global survivorship and what are the opportunities for global survivorship? As we put a greater emphasis on curing cancer and raising survival all over the world, and, the opportunity for global survivorship will happen. So, what are your thoughts as we move over the next few decades for, disseminating what's been done in the United States and Western Europe and other countries into to other countries?
So I think globally, groups are working to develop infrastructure and capacity that allows them to deliver cancer care and track early outcomes, especially abandonment and response. And then as they're entering into long-term follow-up, we would hope that those same systems working collaboratively with culturally appropriate groups will be able to integrate the specific priorities for long-term follow-up. I think that that's going to vary by the individual, by the area, and I think that we would be, I'd be remiss to say you need to do this. I think that we need to have individuals with boots on the ground there that we can say this is an ideal infrastructure to track, but we know that culturally people engaging in long-term follow-up or appreciating long-term follow-up may vary, or their capacity to return to a cancer center may vary. And so you may need to make some adjustments about what's going to be practical for your country, your hospital system, et cetera. So yes, I think that we're at the cusp, as there's a big focus on improving outcomes in children with cancer all over the world. Hopefully those same infrastructures will allow us to be able to leverage the same groups as we move forward and collect information about long-term outcomes.
Well, Melissa, our time is drawing to a close, so I want to thank you for a great lecture. I want to thank you for handling questions across the spectrum and across the world. So it's been a good hour and a half, and thank everyone for attending. We'll see you next week. Take care.
All right, bye-bye.